We do have no one less than Dr. Sonu GOEL, who's a brilliant phakic lens surgeon, and we have just 5 minutes left to the course. He'll try to do justice in these 5 minutes, and Sonu, I won't waste more of your time. Thank you so much.
Thank you, Gaurav, for making me a part of this course. And I'm sure in another 5 minutes that have been allotted to me, I'll make you all refractive surgeons in, peanuts. I think what you have heard from all these master blaster surgeons, they drive Ferraris and they are millionaires. But yes, we poor ICL surgeons, and that is what I want, that you all presentees here can start your refractive practice from the moment you reach back to your town. So I think ICL has been a great game changer in the refractive practice, and you need nothing. You as cataract surgeons, you have all the armamentarium that is required for a safe refractive practice. So just skipping 5 minutes I have. So we all know that these phakic IOLs have been a part of the spectrum of the refractive surgery. They have shifted from the angle supported to the posterior chamber. And the beautiful concept of the posterior chamber basically allows to the lens to sit right in the nodal point, giving you a very stable location, and gone are those days where you have a lot of uveitis, secondary glaucomas and stuff like this, and they are easy to remove. So reversibility is one of the key factors with these posterior chamber phakic IOLs. We all know the right candidates as refractive surgeons: age, refractive stability, and the corneal considerations to be taken when you are assessing the patient for the phakic lenses. And the key important factors in deciding is the sizing of the ICL. So the sizing basically depends upon the two key factors: the ACD. The ACD is basically the endothelium. A lot of people have a lot of confusion in this, and as per the US FDA it is 3, but for the Indian consideration we are taking 2.8, and it is the endothelium. So this is one key factor where as refractive surgeons you should never ever compromise on the anterior chamber depth measurements. Different equipments have different calibrations, but what we use is the pentacam, which we believe is the gold standard for measuring the anterior chamber depth. And white to white we use the digital calipers, though you can whenever you in doubt you can take the readings from different equipments, the IL Masters or the pentacams, but what makes me feel best is the white to white on the digital calipers. So what I have been given is ICL in low myopia, and believe me, ICL, whether the refractive error is low, moderate or high, it works equally well. And the indications could be the refractive, LASIK rejects, and there are certain off-label indications to be used after refractive surgery where you have those patients with refractive surprises, patients with the post-penetrating keratoplasties, ICRs, patients post cross-linking, and sometimes you have those pseudophakic surprises. The basic concern we as refractive surgeons would always have: what is the efficacy in low diopters? Predictability. Is it safe? And what about the low cylinders? Because normally as a nomogram less than a diopter, we would always take just the spherical correction. So yes, here is the gameplay where when you're doing a LASIK or a PRK or a SMILE, you're addressing cylinders as low as 0.25 diopters, which you are leaving untreated when you're doing an ICL surgery. So this beautiful article published in the JCRS comparing the 2-year visual outcome head-to-head between the ICLs and the small incision lenticular extraction, that is SMILE, for diopters less than -3. This beautiful paper, takes care of all your doubts. So efficacy, if you compare the post-operative efficacy indices, which is basically post-operative uncorrected divided by the pre-operative of the ICL and the SMILE group, were all comparable. The safety indices, again, the post-operative corrected divided by the pre-operative of the ICL and the SMILE group were quite comparable. And when you talk about the endothelial cell density, there was no statistical significant difference in the endothelial cell count before and after surgery. So this is a small study for over a 2-year period. So ICL stands safe in low diopters as well. And when you talk about the predictability, you see here the spherical equivalent of all eyes in both the groups, the ICL and the SMILE group, were all comparable. Yes, a small point here, the residual astigmatism was within 0.25 diopters in 80% of the ICL eyes, comparable to almost 100% of the SMILE eyes, where they were able to correct the cylinders to almost near normal. Now this is one very important point. Just 30 seconds to conclude. So HOAs and specifically the vertical coma in the SMILE group were increased after surgery. So both the ICL and the SMILE, they lead to a significant increase in the post-operative HOA, but when you compare both, SMILE leads to a slight more induction of vertical HOA. Again, this beautiful paper in the American Journal from the Chinese group mentioned the increase in the 3rd order, 4th order, and the total HOA after ICL implantation were significantly less. So to conclude, ICL is comparable, it's safe, efficacious, and gives you a long-term visual stability. So you have that EVO advantage. You leave the cornea version, there is no thinning, there is no risk of ectasia, the refractive stability, and there is no regression. It is minimally invasive. There is an immediate recovery, so there is a very short recovery time. It's predictable, induces less higher order aberrations. And what is more important, when you compare head to head, it gives you a slight better contrast sensitivity as compared to any refractive on the cornea platform. It's reversible. And the last and important, what we all share, is the investment-free approach with these phakic IOLs. So thank you so very much, and all to Dr. Chitra.
Thank you very much. I think we should not be holding the next session, and Dr. Purendra Basin is not going to be happy. But thanks a lot for being with us. I do hope you're going back with some of those traces of doubts which may be there in your mind, and we are always there to answer any of your doubts at any point of time during the conference and beyond. Thank you very much.